Good evening, everyone. So, this class is for Year 3 Birmingham medical students. We are going to have a comprehensive class, maybe for next 1 hour, if needed, even an hour and a half, to go through a kind of introduction to urology. There is a good possibility most of you may not have heard about urology, what kind of diseases are related to urology, what kind of organs are related to urology, etc. Obviously, you know few things from your anatomy and physiology, but the disease part of it is the one we are going to cover today. And urology is a very beautiful specialty. Just because I'm a urology consultant, I can vouch for it and I can try to attract you all in. So, one third of all the surgical admissions are urology because urology has a good component of acute presentations, and it has more impact on the quality of life. And there are a few things which may be even life threatening in urology. It requires multidisciplinary interactions. There will be an input from radiologist and oncologist and chemotherapist, etc. So those are all the one. I'm quite happy for the closed captioning, and if I have to do anything, please let me know. I'm happy for you guys to change it if needed. And I will also have a look into the chat on and off. Yes, it's recorded, so you will be getting a full recorded version maybe in a week's time. And there are lots of innovations in urology. That's the beauty of urology. It's quite a nice field where a lot of investigations, trials, and randomized control studies are happening. And we can also revisit some physiology and anatomy because that will help you to understand the urology better. Now, the urology consists of kidneys, ureters, bladder, and the urethra. So, as you can see in this film. So, in this film, I have purposefully removed the kidney, and what you are seeing is predominantly only the collecting system. So, these are all the calyces with infundibulum and pelvis and the ureter. The ureter joins the bladder, and bladder exits via the urethra. Okay. Please mute yourself. I can see some background noise. This complete system is impervious to urine, which means the urine can't seep outside. If it happens, it is known as urinoma, which indirectly means that patient has got some problem to address. There is no need for attendance code. Don't worry about that. We will take the attendance from the participants list. And we will discuss few things like urinary carcinogens in these presentations. And as you know, the kidney has got one of the largest blood supply of organs in the body, and the urine is produced continuously. The urine should be sterile. There is no reason for the urine in the upper tract especially to be infected. But as the urine flows down, we may get some commensals in the bladder and urethra. I need to request you guys to mute. I will see somebody. I'll mute them. Okay, that's good. And the next thing is, as I said, it's a unidirectional flow. We want the urine to come from top to bottom, and so the urine will always come from the kidney to the ureter, ureter to the bladder, and bladder to outside. There's no way the urine should go in the opposite direction. If it happens, it is known as urethral reflex, and reflex is not a good thing to have. Very common in children and not very significant in adults. Okay, I'm keeping an eye on the comments. And stagnation, reflex infections are the main things by which we can get pathology in the whole urology one. Little bit on the curriculum. The curriculum has slightly changed because of this medical licensure exam, MLA exam. But overall, urology has not a big impact. So it involves skills like, for example, history taking. You need to know about lower urinary tract symptoms, hematuria, pain. Examination wise is more of genitalia, abdominal examination, and also digital rectal examination. It's quite unique that not only this specialty, even the colorectal and gender surgeons will deal upon the digital rectal examination. And you may be doing some procedures. The digital rectal examination and bladder catheterization are the two common important procedures. And the topics, the predominance in urology are uro-oncology, UTI, stones, erectile dysfunction, various imaging in urology, special investigations, and urinary tract obstruction, which can be upper or lower tract. Okay, the recording is happening in the background. Don't worry about that. Okay, now, so in the nutshell, you need to have these symptoms and what are all the relevant knowledge you need to know according to the symptoms, and what are all the relevant diagnoses which you may be coming across in these kind of patients. So for example, urinary symptoms means you need to know about the maturation cycle and pharmacology of, say, alpha blockers, 5-alpha reductase inhibitors, anticholinergics, which act during that phase. And from that you can learn overactive bladder and benign prostate hypertrophy. Urinary incontinence means you can know about urodynamics, and that brings out to the diagnosis like stress incontinence and neuropathic bladder. If you read about PSA, patient can present with increased PSA. That takes you to the knowledge about digital rectal examination, trus biopsies, MRI scans, various prostate zones, etc., which leads you to the diagnosis about the prostate cancer. So similarly, of course, you are going to get this presentation, so you know what kind of symptom could result in what kind of knowledge you need to know and what kind of diagnosis you are supposed to come out of that. And if you come to the diagnosis, there are a total of 7 steps, which is a little bit common even with other surgical specialties. History taking, physical examination, basic investigations like, for example, urine investigations, blood investigations, CT scans, etc. Specialist investigations like, for example, nuclear scans, PET scans, or MRI scans, which comes in the imaging. Endoscopy. Endoscopy means looking inside the body. In the urology, we can specifically call it as cystoscopy. Cysto means bladder, scopy means looking inside. So if you're looking inside the bladder, it is cystoscopy. Outside the urology, there are other things like, for example, esophagoscopy, tracheoscopy, sigmoidoscopy, colonoscopy, which belongs to other specialties. And if there is anything suspicious, we need to go for biopsy. Background knowledge, better to know about embryology, anatomy, physiology, and various risk factors for the diseases. Embryology and anatomy, I think you guys are quite thorough, completed everything in year 1 and 2. Physiology, little bit we will cover today. And the physiology mainly consists of the bladder cycle, how the bladder getting filling phase and voiding phase, etc. That is maturation cycle. And we'll go through various risk factors for various urological diseases. So anatomically speaking, this is what urological organs look through. I'm sure you all will be familiar. We all have 2 kidneys, which is capped by the adrenals, usually supplied by single renal artery, but at times it could be multiple renal arteries, drained by the renal veins. The renal veins join the IVC, and the IVC takes the blood away from the kidney, while the direct branch renal arteries supplies the blood from the aorta. And as you can see here, the kidney filters the urine, it passes through the ureter. The ureter is bilateral, it has got gonadal vessels along it, and when the ureter crosses the blood vessels, there is a small hump. This is one of the physiological kind of a kink or obstructive area. It's important to know because there is a good possibility if there is a stone, this is the commonest area it will lodge in. If the stone manages to pass through this area, the commonest area is the junction of the ureter with the bladder, and this is the bladder which leads to external genitalia. Now let's start with one of the basic urology symptom, lower urinary tract symptoms. It is divided into 2 parts. One is the storage symptoms, the other one is the voiding symptoms. Storage symptoms are mostly due to problems with the bladder. Bladder's job is, during the resting phase, it should hold urine and relax, should not stimulate that particular person to go to the toilet. In the voiding phase, it should empty completely and should not retain urine during the voiding phase. So if there is a problem in the bladder, it can cause problems like daytime frequency, nighttime frequency, urgency, and incontinence. The nomenclature is quite self-explanatory, but I'm quite happy to stop and explain if there are any specific queries. Urgency means quite uncontrollable sensation when a person needs to pass urine. So for anyone, male or female, if they want to pass urine, they should be able to defer maybe 10 minutes or half an hour depending upon the environment. But if there is urgency, that particular person can't hold the urine, they may have to really rush to the toilet, and if any leak happens before they reach the toilet safely, that is known as urge incontinence. So that brings us to the next topic of incontinence, which can be urge incontinence if it happens like few minutes before actual urge to pass urine. Stress incontinence when the person stresses the abdomen, like coughing or lifting heavy weight or climbing up the staircase, etc. And overflow incontinence, again the nomenclature is so beautiful. The bladder is completely full and it overflows, that is overflow incontinence. Anatomical incontinence means there is some problem anatomically, like for example vesico-vaginal fistula, which means there is a fistula between the bladder and the vagina, which results in incontinence. So these are all the storage symptoms. Voiding symptoms are predominantly due to the prostate. So it can start with hesitancy, which means the patient is not able to start passing urine. He needs to really struggle. There is a hesitancy before starting urine. Poor stream, after starting the urine, the stream is not brilliant, it's quite poor. Terminal dribbling, when after finishing the urination, there is some dribbling happening, that is terminal dribbling. And post-micturition dribbling, which means everything is complete. If they are about to dress up and come back, but if there is any dribbling happens, that is post-micturition dribbling. So this is the micturition cycle. We are discussing the normal one. So this is the empty bladder. The bladder is getting slowly filled up. Patient gets the first sensation of voiding, and then bladder is nicely filled up. It gives the normal desire to pass urine, and patient passes urine, and then bladder goes back to the nice compressed empty state. So the state till starting of passing urine is known as storage phase. Once the urination is started, it is known as emptying phase or voiding phase. And then once the urination is complete, again storage phase starts. Okay. So if you see the normal resting bladder phase, detrusor muscle relaxes, sphincter tone is high and it is closing the bladder, and pelvic floor tone is high and normal. Patient is comfortable. When patient gets the first sensation to pass urine, you will get a kind of detrusor muscle getting relaxed, urethral sphincter contracts, and the pelvic floor also contracts. Just give me 1 minute. Jana, please close the door. And then when the patient tries to pass urine, you can see that the detrusor muscle nicely contracts, that sphincter is nicely relaxed, that results in emptying of the urine, and pelvic floor nicely relaxed, that results in the maturation. And after completion of everything, the bladder goes back to the first stage of detrusor muscle nicely relaxed, and urethral sphincter tone and pelvic muscle tone were high. Okay, so this forms the complete maturation cycle. So this voiding happens 6 times, 8 times in a day, while rest of the 24 hours it will be of filling phase. Okay, now how will you assess the lower urinary tract symptoms? So essentially we got symptom questionnaires. I will show you that. We can do a midstream urine to look for any infection. We can do a blood test measuring the urea and electrolytes, and also blood test PSA for men. We will discuss that in quite detail. We have bladder scan. They are all small portable scans available in the clinics, where when the patient passes urine, after finishing the micturition, we can do the bladder scan to make sure that the bladder is complete or is there any residual urine. And we have a frequency volume chart, which tells us how frequently patient passes urine and what is the volume of urine every time. Okay, so these are essential basic assessment tools. Optionally, or maybe in the second clinic visit, patients will get additional tools like flow rate. Flow rate means patient will pass urine and we'll measure how good the urine stream is. We can do plain x-rays, we can do ultrasound, CT scans, urodynamics, and cystoscope. I'm going through each and every one in the next few slides. So this is the symptom score for lower urinary tract symptom. As you can see, we are quantifying 7 symptoms. They are quantified from 0 to 5. So if the symptom is very worst, it will go for the score of 5. So a patient can be scored to a maximum of 5 into 7, 35. So this will be reported as a IPSS score of 28 out of 35, 30 out of 35. Okay, 35 may be the worst score when a patient has all the symptoms and it's completely present always. If you see, it's a very easy to remember. If the patient has absence of symptoms, it just scores 0. Presence of symptoms like 1 in 5 times on the day, it's 1. Half of the time it's 2. About half of the time it's 3. More than half it's 4. And almost always, if patient says, every time when I'm passing urine, my urinary stream is weak and I need to struggle to pass urine. That's almost always. So depending on that, for example, the weak stream, we can mark it as 5. It's better to give this sheet to the patient so that patient can understand, take his own time and think how his day is, and then he can fill himself. Examination. During the examination, we can do like suprapubic tenderness. Is there any palpable bladder? How is the consistency of the abdomen? What is the shape of the abdominal wall? Penile structures, external genitalia. Is there any obvious abnormalities? External genitalia examination. As I said, digital rectal examination done both for male and women, male and female, and vaginal examination obviously for women. And this is the flow rate, as I said. So for example, this is a very good example of a normal flow rate of a man, where a man can produce good urine stream. The urine speed goes up to almost 20 ml per second and he empties it within appropriately say 20 seconds or 30 seconds, something like that. If there is a blockage, he won't reach that good speed and there is some hesitancy and there is some terminal dribbling. It's a very typical example of patient with voiding urinary symptoms. So normally the flow rate is between 10 to 15 ml and any patient more than 70 years of age, slowly the symptoms will be quite common. And what are all the causes for a patient to have voiding problems? As I said, we have 2 sets. One is storage problems, the other one is voiding problems. So voiding problems could be due to UTI. The bladder can cause voiding problems like overactive bladder, bladder outlet obstruction. It could be cancer of the bladder or the prostate. In a woman, gynecological problems, say for example prolapse. If vaginal prolapse happens, it can cause bladder outlet obstruction, resulting in a woman to have voiding symptoms. Stones can cause problems and fistulas can cause problems. And this is how a benign prostate will progress. So normally prostate is quite almost of a size of a good sized almond. But when the benign tissue is growing, it can go even to the size of a small clementine or an orange. Okay, so when the prostate gets bigger, you can see slowly the bladder has got the secondary changes, the wall getting thickened, and also you're getting the diverticular trabeculations, etc. And the stones can also form if the obstruction is not relieved in the appropriate time frame. How will you manage the urinary symptoms? First starts with conservative management, like not much of coffee and tea, good amount of water, treating constipation, and making sure the timing of voiding is nicely adjusted. As I said, the medical therapy is predominantly for prostate, it is alpha blocker and 5-alpha reductase inhibitors. I don't think at your stage you need to know all these medications. And for the bladder, it is anticholinergics. If patients are not responding to the medicine, they will end up in surgery. There are lots of surgical options available. Predominantly, I wish you all to know about TURP, which means transurethral resection of the prostate. Maybe in a year 4, when you are having that 1 week of urology placement, I'm very sure when you're coming to the theater, you will be seeing TURP during the week. Okay. And now, urinary incontinence. As I said, the incontinence can happen if the bladder is completely filled. We call it as overflow incontinence because the bladder is too much filled, but the outflow is not opened enough, so patient will have some urine leak due to overflow. Stress incontinence is the one where patients cough or heavy lifting of any object. That stress of the abdominal wall is transmitted to the bladder, that results in urinary leak. Urge incontinence, as we discussed, everything is normal, but because of the instability to the bladder nerve supply, patients can't hold urine till they reach a appropriate safe phase for emptying. So that results in urge incontinence. So urinary incontinence can be genuine stress incontinence, which can be a congenital weakness of the bladder, pelvic floor mechanism, estrogen deficiency in elderly, postmenopausal women, etc. And it could be due to detrusor instability, due to retention, fistulas, temporarily due to UTI, or maybe urethral diverticulum. So these are all the causes for the urinary incontinence. And ending up with a kind of a very complex investigation, which is known as cystometry. I'm pretty sure at your stage you don't have to know, but the overall idea is during the cystometry we try to fill the urine bladder with the help of the normal saline, and with the help of a catheter we'll fill the bladder with normal saline. We use another catheter in the vagina or in the rectum based upon male or female. That gives us the measurement of what is the pressure happening inside the bladder. That gives a very good idea where is the fault. Is the bladder is the culprit or prostate is the problem? Depending upon that we can tailor the treatment. Okay. If a patient is coming with urinary incontinence, again the treatment can be conservative, which means again try to avoid caffeinated drinks, avoid constipation, good amount of hydration, stop smoking, and try to avoid excess of alcohol. Sometimes patient may need catheter if it's a overflow incontinence. Medications, as we discussed in the previous slides, and sometimes for stress incontinence there are various surgical options available. Again, these surgical options are quite advanced for your age. Usually tapes that you can easily remember, so we can put some tapes or mesh to further strengthen the urethral neck so that the incontinence will not happen. That may be one of the easiest way to remember. We'll have a minute or two discussions if there are any questions. Any burning questions? I am planning to have at least 2-3 small breaks so that it's good for you to ask some questions then and there rather than leaving it till the end of the lecture. No questions? Okay. If there are no questions, I'm happy to proceed, but have a notepad and make a note of the questions. Now, coming to the other common scenarios, like for example, hematuria. And hematuria is blood in the urine. So it can be divided into like visible hematuria, where you can see that there is some blood in the urine. Non-visible hematuria, the name is self-explanatory. You can't see with your naked eye, but the hematuria is noted when we do a urine dipstick. Urine dipstick is a test where the urine is dipped with a kind of a dipstick where it can tell you the urine's pH, presence of blood, ketones, and sugar, hemoglobin, bilirubin. So there are 8 to 9 columns by which we can measure so many components of the urine. So the blood is not seen in the naked eye, but it is present in the dipstick. And the patients can be symptomatic or asymptomatic. The investigations for hematuria are almost similar to the investigations for lower urinary tract symptoms, like the blood investigations of foot blood count, UNEs, midstream urine. They are quite essential. And since hematuria is a sign of possible cancer, it is labeled as a red flag sign. Since it's a red flag sign, we need to send the urine for cytology. Urine cytology is a method where the urine will be spun in a kind of a machine to get sediment, and the sediment is looked for any malignant cells. That is urine cytology. And in man, we will be doing PSA test. I will be discussing PSA test quite in detail in the future slides. And CT scans, the other imaging, like for example, ultrasound. Retrograde pyelogram is the one where a patient will be put to sleep we'll put some contrast into the urine passage. If you remember the initial slides where I've shown the kidney with ureter, we can evaluate the whole ureter by using the contrast material. And similarly, MRI scans or endoscopy or directly looking into the bladder, which can be like a flexible endoscopies or rigid endoscopies, and ureteroscopies if you're going to the ureter. So if it is a scopy for ureter, it is ureteroscopy. If it is a scopy for the bladder, it is cystoscopy, because cysto is the actual medical nomenclature for the bladder. And if there is a need, we need to do the biopsies as needed. So this is a very good example of a flexible cystoscopy. As you can see, the surgeon is looking through the eyepiece and passing this cystoscope through the urine passage, having a look inside. We can fill the bladder by using the normal saline. Here in this picture, this patient is quite comfortable and smiling, but usually the investigation is not that pleasant, and sometimes patients will be quite uncomfortable with that. So this is one of the commonest example where you can see that the bladder has got a lesion. This lesion is commonly a transitional cell carcinoma. It is slightly out of focus, but I'm very sure you all can appreciate it's a kind of a lump. Possibly you may have come across these kind of lumps mostly in the skin disorders. So if there is a lump, the treatment is transurethral resection. So through the urethra, a camera will be passed under anesthesia by using the hot loop. We need to shave these tissues off, just like shaving a tree, for example. And then we need to make sure that the whole thing is shaved, including some muscle, because we need to take the muscle to make sure that the muscles are clean and muscles are not involved. Because as long as the bladder cancer is not involving the muscle, the treatment is very conservative, which means we will preserve the bladder. But if it involves the muscle, patient may end up having radical cystectomy. As I said, cysto means bladder, cystectomy means removal of the bladder, which we will see in the future slides. Now, little bit on the staging, because at least one of the organ staging is better for you guys to know. So for example, for the bladder, if the tumor is quite superficial, it is known as PTA. Here the P stands for pathological staging, T stands for the tumor staging. So usually any staging happens in the form of TNA, tumor node metastasis. So if there is a tumor, we will stage the tumor, and then if there is any nodal spread, lymph node spread, we will stage the lymph nodes, and if there is any metastatic spread, we will stage the metastasis. Say for example, metastatic spread can be M0, M1. M0 means no metastasis, M1 means there is some presence of metastasis there. In some specific diseases, say for example prostate cancer, we even say it's M1A and M1B, because the bone is one of the commonest organ for prostate cancer to spread. So we have a separate category for M1B. And for example, nodal metastasis, you may have read in the anatomy, any organ, if you take, there will be a primary node and the secondary lymph nodes. Say for example, for the lungs, if you take axilla, axilla is one of the primary lymph node collection. For the urology, for the bladder, the iliac lymph nodes were the primary lymph node drainage, while aorta is the secondary lymph node drainage. So if the lymph node is only on the primary area, it is N1. If the lymph node involvement is up to the secondary area, it is N2. If the lymph nodes were not involved, it's obviously N0. Okay, so T, N, M, T for tumor staging, N for lymph node staging, M for metastatic staging. And in this T, again you can see it increases from superficial to the deep. As the tumor gets into higher stage, the number will increase. So first one is PTA, which means the tumor is quite superficial. T1 means it involves the lamina propria, which is the innermost layer of the bladder wall. PT2 means it involves the muscle. The muscle is coated as green color, and once it reaches PT2, it means the bladder needs to come out, or there are various bladder preservation surgical options are also available. And P3 means the tumor has spread outside the bladder. P4 means the tumor is involving the surrounding organs, like for example prostate, etc. and what are all the various ways by which we can risk stratify. So any tumor, whether it's a lung cancer, brain cancer, bladder cancer, prostate cancer, we always stratify the patient's risk by using few criterias. So basing upon the criterias, we'll make it as a low risk category, medium risk category, high risk category, or quite severe like muscle invasion type of category, which I showed you in the picture. So people with low risk, TURBT, which is the procedure what we have seen. This one is known as TURBT. So TURBT is transurethral resection of bladder tumor. After that, we can instill some chemotherapy into the bladder, which is known as mitomycin. If the patient has got medium risk, the same mitomycin installation to the bladder will be repeated for 6 times. If it's a high risk patient, there is a therapy known as BCG therapy, or very rarely patient may go even for radical cystectomy. Cystectomy means, as I said, cysto means bladder. Cystectomy means removal of the bladder. If you are going to remove the bladder in total, including the lymph nodes, fascia, connective tissue, everything, which is what we do in cancer, it is known as radical. If the bladder needs to be removed for non-cancerous reasons, there is no need to remove the lymph nodes, fascia, etc. We can just remove only the bladder. So it is known as simple cystectomy. Even though the name says simple, the procedure is quite a tedious one. Okay. And if the patient has a definite muscle invasion, as I said, we have two options: radical cystectomy, or we can preserve the bladder by using some radiotherapy. So any cancer, not just for urology, risk stratifying, based upon the stratification of the risk, we need to tailor the treatment. And what will be the bladder cancer outcomes? 70% of the tumors will remain superficial. They will have excellent outcome. They may not have death due to the disease. They will die because of other reasons like cardiac or old age. But 30% of them, the bladder cancer may be the reason for the death. The tumor can become quite invasive, or it can be even becoming metastatic. As I said, invasive cancers will require surgery at 60% of the time, and the survival is 60% in 5 years' time. If the patient goes for radiotherapy, the survival is pretty poor. So bladder cancer, as long as the patient is nice and fit, as long as the tumor is present within the bladder, surgery has better outcome compared to radiotherapy. And now we'll go to a different organ. We are going to the upper tract, renal cancer. So this ultrasound shows there is a mass lesion here. It's not very clear in the ultrasound because ultrasound is not the investigation of choice for renal cancer. But a lot of times when GP orders an ultrasound, that may be the first point where some suspicious lump is noted in the kidneys. So you can see that this is the normal kidney drainage, but here you can see the color is slightly hypo-intense, and that's where the hypoechogenic mass is noted. So sometimes a patient may have hematuria, but not always. Sometimes it's incidental, which means patient just went for scan for some loin pain or some non-specific weight loss, etc. But it's discovered in the scan or CT scan. And the tumor types may be like a kidney cancer, which is the most commonest. The other one is the collecting tubules cancer, which is known as transitional cell cancer. And there are other various rare types which possibly not in your curriculum. To evaluate the renal cancer, the best way is to see whether it's solid or cystic. If it is cystic, we need to have some characterization for that. And if it is solid, the chances of malignancy is quite high. We need to know the other kidney conditions. What about the other kidney, whether it's healthy, so we can safely remove the one kidney. You may know that the patient can easily lose one kidney and have a long healthy life, even though at least documented evidence says that if somebody is losing the kidney either by donation or by cancer or due to stones or even absence of kidney from birth, if they live in solitary kidney, chances of hypertension and chances of future renal failure is slightly on the higher side. And we need to know the baseline kidney functions. Is there any signs of advanced disease? As I said, all cancers can spread. So kidney cancer can also spread to, say, local lymph nodes or to the liver or to the lungs. So we need to see, is there any metastasis of the cancer? So this is one example of a pathological specimen. So you can see this is a kidney, and you can see here the calyces are all quite nice and normal, and this possibly we can label it as artery and vein. There are two lumen structures, and this is the pelvis where the urine drains, and pelvis continues as a ureter. But the most conspicuous thing is this cancer, which is lobulated multiple consistency cancer. This is a quite characteristic picture of a kidney cancer, and CT scan is the investigation for kidney cancer. You can see that the kidney is completely replaced by the cancerous tissue. Here it appears as it is involving the abdominal wall, but you can't make a decision just with one CT scan cut. You need to see the full CT scans to make sure that whether it's involving the neighboring organs or not. But you can see that the opposite kidney is normal. The bowels also lighted because the patient had oral contrast also. This is the spinal bone, so patient is lying on his back. Okay, a small discussion time. Any burning questions? I can see in chat. If the renal cancer is cystic, what do you mean by characters? Yeah, if the cancer is cystic, then we need to characterize the cystic nature of the swelling by some measurements. Say for example, is it a simple cyst just like a balloon where it contains a clear fluid, a simple nice thin walled cyst with a clear fluid? Okay, if this happens, it is known as type 1 cyst. This classification was made by a pathologist by name Bosniak. Okay, so there is classification of Bosniak: type 1, type 2, type 3, type 4. Type 1 is a simple cyst, no suspicion at all, and the chances of cancer is absolutely zero. Bosniak type 2 is the one where the cyst wall is slightly thickened, but if you give contrast, it is not lighting up. So it is still again a benign finding, and Bosniak type 2 cyst doesn't require any follow-up. But if there are any special features like thickened septum, and if there is any nodules in the wall, then the type 2 will become type 2F, which is known as type 2, but it requires follow-up. So it's called as type 2F. Type 3 is the one where if you give contrast, it lights up. That means something bad happening in the cyst, something like malignancy. Type 4 is a definite cancer. It is known as cystic type of renal cell cancer. So if there is a cyst, we need to characterize it. But if it is a solid tumor, there is nothing to characterize. We know it's definitely a cancer. Good question. One more question. Yeah, that makes sense. Very good. If there are any other questions. Okay, we'll go to the next one. Now we have finished the bladder cancer, we have finished the kidney cancers. Now we are going to the lowermost organ, prostate cancer. Prostate, as you know, is an organ present in the neck of the bladder, present only in men, and the commonest blood investigation to evaluate the prostate is PSA, which stands for prostatic specific antigen. So it is a blood test. The antigen is present in the blood, which is very specific only for the prostate. Okay, and protease enzyme is secreted in the seminal fluid. So the seminal fluid is the one which releases the protease enzyme, and small amounts of this released into the bloodstream. And if this small amount is released, which means it's normal. So any man, maybe even from the age of 20, if you do a blood test, there will be some amount of PSA present, because even a benign, soft, normal prostate will produce PSA. But once there are some cancerous changes, there is a shoot in the PSA value, and depending upon the severity, as I said, risk stratification, you will be seeing quite significant increase in the PSA. Or urinary catheters, a long-term method for management of outflow incontinence. Would the removal of urethral obstruction not be the primary routine treatment? Yes. I mean, it's not necessary for the patients to get the catheter always. When, for example, if the obstruction is due to the prostate, our aim is to treat the obstruction by using surgery, which is transurethral resection of the prostate. We will clear the prostate to make the prostate cavity bigger, so that we'll try to make the patient free of catheter. Very rarely, very elderly man, elderly woman, the condition is uncurable. Those kind of situations where the patient will end up in catheter for long term. As a surgeon, we always wish the patients not to end up in lifelong catheter. Okay. So coming back to the PSA, the PSA is bound tightly to the plasma proteins, and it can be increased in the case of enlarged prostate, prostatitis, and our main worry is the carcinoma of the prostate. So if enlarged prostate, it will increase only very minimally. Prostatitis, since there is a infection and inflammation in the gland, there will be a surge in the prostate PSA value, but it won't be too bad. And as you can expect, prostatitis is a temporary situation. It's just like upper respiratory tract infection. Once the prostatitis is cured, the PSA will come to normal. The most ominous one is the prostate cancer, where the values will increase, and unless intervened, the follow-up values will always show some progression. Okay. Now, so this picture shows us the prostate, which is present in the neck of the bladder only in men, and this shows the prostatic ducts, which releases the prostate specific antigen into the blood. So if you do the blood test, you can see the PSA, and PSA is again divided into like free PSA and bound PSA, but those things are not in your curriculum, so don't worry too much. PSA measurement in the blood is a good value for you. And depending upon the values, we can say probability of the cancer. If the PSA is like 0 to 2, the chances are 1%, 2 to 4, 15%, 4 to 10, 25%, more than 10, more than 50%. And the free PSA, I don't think it's in your curriculum, so don't worry much, unless if you want some expanded reading. As you may seen, there is a separate lecture on the prostatic diseases, both benign and malignant, in the Canvas page for year 3. It's more of extended reading, but it's good to read, because if at all, if you get an MCQ or OSCE questions on the urology, the chances of it related to prostate is very, very high. So that's why we try to keep prostate little bit extra importance and given some extended reading. Okay. So as I said, a man's prostate has got some normal PSA, and a man, as he getting older, that normal prostate also will slowly increase in size. So that's why you will see the PSA for elderly men are slightly higher compared to the younger men. So depending upon the age, Altstring decided 2.5 is the cutoff for those between 40 to 49, and similarly for every decade of the man, it increases by 1. But if you notice, there is a jump by 2 in the age of 60, because in the age of transition from 50s to 60, prostate really grows at a very rapid speed. So that's why there is a jump for even the benign value. So any patient with this PSA value on this age criteria and below, they are all normal. Okay. And prostate anatomically consists of various zones. So this is the urethra. As I said, the prostate is present around the urethra. The innermost one is known as periurethral gland, and then it is surrounded by the transitional zone and also the central zone, and then it is surrounded by the most outside peripheral zone. Peripheral zone is the commonest zone in which the cancer can happen, while the normal benign growth will happen commonly in the transitional zone. Prostate cancer is a cancer of elderly. So if you see, the chances of finding a cancer less than 40 years is almost nil. But once the patient reaches the age of 40, 45, the chance of cancer slowly increases, and it decreases once they reach 80, because most probably the longevity is not there, or patients are dying due to the other reasons. Prostate cancer is one of the commonest diagnosed cancer. It superseded even the lung cancer, and solid cancer I mean, because skin cancer is the commonest one. There are some blood cancers also, but solid organ cancers, prostate cancer is the commonest cancer in UK on lots of countries as of now. Maybe because of good programs to quit smoking, I think the lung cancer is now become the second commonest, and prostate cancer is now the most commonest. So patients may present asymptomatic with raised PSA, and sometimes if we do the examination of the rectum by using a gloved finger, you may be feeling that the abnormal DRE. Patients can present with urinary symptoms. If the prostate cancer spreads to the backside like lymph nodes or bones, patients can present with backache. Symptoms of metastasis. Sometimes if there is a metastasis to the brain, patient can present with like syncope, confusion, memory loss, etc. And there are some symptoms of local progression. For example, the prostate cancer can spread to seminal vesicle. So when the patient has sex, during the ejaculation, the ejaculate may have blood. And prostate cancer can spread to the bones of the pubis in the lower tummy. So patient can present with like a significant swelling or pain in the bone of the pubic bone. Okay. And this is one of the histological finding, and there is a pathologist by name Gleason. He divided the histology of the prostate cancer into Gleason score 1, 2, 3, 4, 5. As you see in Gleason score 1, the gland is relatively nicely preserved. When the gland architecture is lost with loss of loosening, it is Gleason 2. When the architecture is lost with the multitude of multiple different shape cells, it is 3. When there is a conglomeration of the cells into patches, it is 4. When there is complete dysplasia, it is 5. So again, a method of risk stratification based upon the biopsy. We can, Gleason 5 is the worst performing cancer, while Gleason 1 may be the good cancer. And as you see in the picture, this is the way we use the gloved finger to pass through the anus and examine the prostate in the lower rectum. And with the other hand, you can support from the lower tummy, so that the prostate is a gland which is accessible by digital rectal examination. And so the diagnosis of prostate cancer can be done by blood test PSA, by biopsy of the prostate. As I said, when we resect the prostate because of urinary symptom, that tissues, when you send for histology, that can show you the cancer. And staging can be done by the examination. We can do a bone scan. This is one of the example of the bone scan where you can see some hot spots, which means the prostate cancer has spread to the bone, and the bone is got metastasized. Okay, CT and MRI are one of the commonest investigations used. So this is how the prostate biopsy is done. We will pass the scan probe through the back passage. Using the scan, we can see the prostate in the monitor. You can see this is the prostate here, and then use the needles to take the biopsy from the prostate. That is the ultrasound guided prostate biopsy. So this is a MRI scan, which is very specific and most sensitive one, and MRI can pick up some areas where the possibility of cancer is there. I don't think you need to get too much into that, but if you get an OSCE scenario, maybe in year 4 for evaluation of the prostate, evaluation of increased PSA, evaluation of prostate cancer, you will be able to easily demonstrate the use of a blood test PSA and investigations like biopsy and also the MRI scan. And there are various things depending upon the stage of the disease. So before the diagnosis and localized disease. So when before the diagnosis, the main thing is what is the patient's symptom. So is the patient is completely asymptomatic or not? And during the diagnosis, our aim is to make sure that we diagnose and stage the disease. If the patient has got localized symptoms, it may be a localized cancer, or it could be locally advanced cancer. As I said, the prostate cancer can spread to the local organs like seminal vesicles or pubic bone, or it could be a metastatic disease if it spreads to the bones and lymph nodes. Management again depends upon whether it's localized or advanced cancer or metastatic cancer. If it is a localized cancer, we can keep an eye on it. If the patient is quite old, fragile, frail patient, not fit for surgery, or we can go for surgery or radiotherapy. So these things afterwards, we will monitor the patient rest of the life. If it's locally advanced, some patients are suitable for still surgery, but mostly they will go for hormone treatment. Why hormone treatment in prostate cancer? Prostate cancer is a disease which is very sensitive to hormones. So as I said, prostate is present only in men. So there is something peculiar which is in men, which is not present in women, which results in formation of prostate, benign disease and malignant disease. The commonest one is testosterone. So since testosterone is a unique one for the men, it results in stimulation of the prostate growth and also differentiation into a cancer. By blocking the testosterone, we can achieve good shrinkage and good control of the disease. And if the diseases become metastatic, again we will be doing hormone manipulation. By hormone manipulation, if you answer a simple question, testosterone blockage, that's more than enough. And then if the hormone escaped disease, which means in spite of blocking the testosterone, if the patient has got progression of the disease, PSA is increasing, signs of some metastasis is forming, it is known as hormone escaped disease. In other words, it is castrate resistant prostate cancer. Castrate means patients where the testes were removed or the hormones were controlled. Either way, castrate. Castrate resistance means in spite of the castration, the patient has become resistant to that and there is a disease progression. If there is a castrate resistant happens, patient will end up only in palliative treatment because we don't have much options to give at the time. And unfortunately, if everything is not successful, patient will be having a death due to the prostate cancer. So this slide gives you an overall idea about various stages of cancer and various treatment modalities available for that. Any burning questions on prostate cancer? Okay, if there is no questions, we will proceed further. Now, after finishing the cancers like bladder cancer, kidney cancer and prostate cancer, we will look into some of the benign conditions. Okay, so how is prostate cancer staged or via metastasis? It's quite simple. So any disease, the staging is TNM. I think I mentioned this, but I will specifically explain so that it nicely gets into you. The staging of the disease, whether it's urology, gynecology, pulmonology, neurology, any cancers, brain cancer, kidney cancer, lung cancer, the staging is always TNM. T for the tumor, N for the lymph node, M for the metastasis. So tumor, we can stage based upon what is the size and what is the spread. So in bladder cancer, you saw that the T stage is based upon T8, T1, T2, 3T, T4. Similarly, for prostate also, if it is within the prostate, is T1, just outside the prostate, T2, surrounding organs involvement, T3, so like that. So form an overall idea. T is for tumor. It depends upon whether it's an organ confined or surrounding organs involved or a little bit closer to the organs were involved. That is T staging. N is for lymph node staging. At your stage, if you remember, N0 means no lymph nodes. N1 means lymph node spread noted. That's it. M means metastasis. Metastasis can happen to say liver, lungs, brain, etc. So if metastasis is present, it is M1. If metastasis is absent, it is M0. If somebody asks you what is staging, say for example lung cancer, the simple thing is TNM, T for the tumor depending upon the size and the local involvement, N for the lymph nodes and M for the distant organ spread. So sometimes the combination will be like T3N1 M1, T3N0 M1. So there are various permutations and combinations are possible. Okay, good. So we have finished a major chunk of cancers. As I said, cancers are commonest in your OSCE or MCQs, of which prostate is the very commonest one. Now we get into a little bit more benign conditions, but also relatively less common from the exam point of view. But in your day-to-day life, in your clinical practice, you may be seeing the stones more frequently than the cancer. So kidney stones create quite awful symptom. For example, if men, yeah, I will take woman. Women having this kidney stone pain, they will equate it to a labor pain. To that level, it will be very, very, very painful problem. So this is one example where the stone formed in the kidney. You can see here also there is a stone in the kidney here, and if the stone slips down, it has to go through the pelvis, ureter, into the bladder, and from the bladder it needs to come out. So at this point they can lodge anywhere. As I said, there are some anatomical places where the kidney stones can get lodged. The one is pelvic-ureteric junction. As you can see, the pelvic-ureteric junction, there is a sudden change in the caliber of the ureter, so the chances of stones getting blocked there is quite high. The second one is the crossing of the vessels, as I show it in one of the picture. The third one is the one where the ureter is just entering the bladder, known as vesico-ureteric junction. Vesico means bladder. We have used it plenty of times in this presentation. So vesico-ureteric junction. So these are the three commonest areas where stones can get lodged. And how to diagnose this? Sometimes it's seen in the ultrasound. You can see that nice white reflective one, and ultrasound works by reflection of the sound waves. So you can see that the sound waves are produced from the probe. It goes and it reflected by something. So for example, if there is a air, the air will absorb the sound waves and you can't see anything. If it's a kidney, if you follow my red arrow, that is the outline of the kidney. Now you can appreciate the kidney. So the kidney reflects the sound waves. That's how you are able to see the kidney. So kidney has got outer cortex, which is hypoechogenic, while the inner medulla is hyperechogenic. In the hyperechogenic medulla, you can see significant hyperechogenicity due to the stone, and stone produces characteristic after stone. There's a shadow. It is known as post-acoustic shadow. You don't have to learn those complex terms, but if you explain that stones can be diagnosed in ultrasound because of the shadow it produces, that's a very good way of explaining it. And it's nicely seen in the x-ray, and the stones are seen, it's just exactly the same stone what you have seen in the schematic diagram. You can see the stone is seen. Obviously you can't see kidney, ureter, bladder in the normal plain x-ray, and the stone's brightness is almost similar to any of the bone. If you give contrast, you can see that the kidney is nicely lightening up. You can see that, and then the contrast is excreted into the pelvis, and the pelvis nicely lights up the whole ureter and also the bladder. If you do a CT scan, you can see that the kidney is blocked, resulting in urine accumulation there, and in the ureter the stone is seen as a bright white spot. Other than that, you have the liver, spleen, stomach, and large bowel and small bowel are there. And we are going to further other minor topics, like for example retention of urine. So patient comes with inability to pass urine. It may be acute retention or chronic retention. So acute retention means it's a painful retention where patient's residual urine is more than a liter. So if you catheterize the patient, or if you do a bladder scan, it usually says it's more than a liter of urine in the bladder, and patient will have excellent relief if you place a catheter. And chronic retention is the one patients got retention, but they won't come with significant pain. Because the retention is chronic, the bladder got accustomed and bladder got nicely dilated. The tone of the bladder is lost, so it can hold a liter or even 2 liters of urine without much problem to the patient. Usually the volume is more than a liter, and it may be low pressure or high pressure. Low pressure means the bladder itself is nicely relaxed, and whatever the liter of urine it holds without any high pressure. While high pressure retention means bladder can't hold in a relaxed manner. It is bit tense. Because of that, the urine getting reflexed back into the kidney, and it can cause significant damage to the kidney if not treated in the quick time frame. And retention, the first one is checking the bloods to make sure the kidney functions are okay, and then catheterize. And there are various types and size of the catheter based upon women or man, and depends upon the age and we can try to have as large as 24 French or as small as 10 French catheters are available. You need to document what is the amount of residual urine after placing the catheter. If it's a chronic renal failure, we need to closely monitor the output, because urine output is one of the good evidence to depend on to make sure how the kidney is recovering after the retention episode. And we need to plan removal of the catheter by giving appropriate medications. Say for example, if it's acute retention due to the prostate, as we discussed in the previous slides, tamsulosin, which is a kind of an alpha blocker, will result in relaxation of the prostate. If you start the medication, it works within 24 to 48 hours, and catheter can be removed in 2 days time, and patient will take the medicines for longer term so that he will be passing urine normally. But good group of patients, if they are not responding to medications, or if the problem is like high pressure chronic retention, it's better to do a surgery. The surgery, if you recall, it's the same thing. We need to go inside, use the hot electric loop to shave the prostate tissues to create the channel, TURP, transurethral resection of the prostate. And so this is an example of how a urethral catheter will work. So if you place the urethral catheter, it has got an eye through which the urine drains outside, and the catheter comes all the way up to outside, and it's connected to the back. And if there is a problem in the urethra, if we can't go through the normal track, then we need to do above the pubic bone. Pubic bone is the lowest bone in the abdominal wall. So we need to go through the abdominal wall and place a catheter. It is known as suprapubic catheter. The catheter is supra to the pubic bone. Infrapubic, suprapubic. So since the catheter goes superior to the pubic bone, it is known as suprapubic catheter. So there are two ways by which you can catheterize the bladder. Any burning questions in these topics? Yeah. So did you say hypoechogenic for cortex? Not sure. Yes, absolutely correct. So to label organ, whether it is high in the intensity or low in the intensity, you remember two terms: intense, echogenic. If you are discussing a CT scan, it's better to discuss like hyper intense lesion, hypo intense lesion. Okay, but if you remember ultrasound, as I said, ultrasound works by the principle of the sound waves. So the sound waves are going in and then echo or reflected back into the probe. So if the organ reflects lot of sound waves, it is hyperechogenic. If it reflects small amount of sound waves, it is hypoechogenic. In a kidney, the outermost part is the cortex, as you know. The innermost part is the medulla. Medulla contains good amount of fat. Fat is very good in reflecting the sound waves. So medulla is usually hyperechogenic, while the cortex of the kidney is hypoechogenic. Stones, since they are quite dense, they reflect the stone completely, reflect the sound waves completely. That's why stones are quite hyperechogenic. And since stones reflect the sound waves completely, after the stone there is a thick shadow forms. Okay, so if an organ is quite dark and seen quite faintly, it is hypoechogenic. If it is quite bright, it is hyperechogenic. The same thing in the CT, you can call with intense or dense. Hyper intense, hyper dense, hypo intense, hypo dense. It's the same thing. Because of the different mechanisms, we are using the different words. Yes, you are correct. For a kidney, the outer cortex is hypoechogenic, inner medulla is hyperechogenic. The reason is the medulla contains more fat, and fat reflects the sound waves more strongly than the cortex, which has no fat. Okay, good. Okay, we have last bit, which is the lumps and bumps of scrotum. And so patients can present with pain in the scrotum. So the first question is it painful or not? If the patient has scrotum or the testicular swelling, but it is not painful, then they will end up in this line of pathway. While if it's painful, they will be mostly heading towards infection like epididymoorchitis or testicular torsion, common in young teenage men, or it could be a hernia. So torsion means the testis rotates on itself due to some congenital changes. Because the testis rotates on itself, testis is supplied by the pedicle, which has got the blood vessels. When you rotate, just like your garden hose pipe, if the hose pipe is getting rotated, your flow in the garden hose pipe tip is getting compromised. Similarly, the blood supply to the testis will get compromised. That results in painful emergency presentation, meaning you need emergency exploration to restore the blood flow to the testes. Epididymoorchitis is due to infection. It can be due to even sexually transmitted disease. The other, which is not so urological, is a strangulated hernia, which is more of a general surgical topic. And if it's not painful, then we need to see whether that swelling is, we are able to get above the swelling. If you can't get above the swelling, it's a hernia again. So a hernia can present in as a non-painful swelling also. If you are able to get above the swelling, it's not hernia, then it should be something to do with the testis itself. So within the testis, non-painful conditions are, it could be cancer, it could be varicocele, which is just dilated veins. Some of you may have some dilated veins in your hand. The same dilated veins can be noted in the testis also. It could be a clear water collection, where if you use a torch and see in a relatively dim dark room, that transilluminates, the whole testis will get illuminated because of the water content. Or it can be a cyst in the epididymis. Mostly epididymal cyst, hydrocele, varicocele can be treated conservatively, but as you can expect, tumor needs to be treated accordingly. Again, testicular tumor, same story. T, N, M. T stage is based upon whether the tumor is within the testes, tumor is involving the epididymis, tumor is involving the scrotal skin, T1, T2, T3. Lymph nodes, whether the tumor lymph nodes spread only to the tummy, and if it goes to the chest wall, T1, T2, etc. Similarly, there is metastasis. If it goes to the lungs, if it goes to the brain or to the liver or to the bone, it is M1. If not, it is M0. Testicular cancer at your stage in any questions is quite unlikely. So I'm not discussing testicular cancer in detail, but prostate cancer, bladder cancer, kidney cancers are important, of which prostate cancer is much more important. The other things I wish you to know, if you are interested much more in urology, or keep it in your mind so that in year 4 when you're coming for the 1 week urology posting, you should know is little bit more on dysuria, UTI, complicated UTI, etc. There is a specialty known as andrology, where men may come with difficulty in having erections and problem in having intercourse or problem in becoming a father. So that's an andrology. And embryology is always a good thing because the kidney ascends from low to high and testes descends from high to low. So the urology is the only specialty where we have two paired organs, kidneys and testes, but embryologically they move in the opposite direction. It's quite fascinating to learn. So maybe you can read it this weekend and you will really enjoy it. Renal failure, it's two-pronged. It may be a nephrological topic where the renal failure is purely due to the kidney, where the cortical function is compromised, or it can be urological reasons like urinary retention, stones can cause renal failure. As I said, if there is a cancer, we have to remove one of the kidney, the other kidney is not good, that can result in renal failure, etc. So these are the other common topics I wish you to know in due course. Okay. So urology is, as I said, a very nice specialty. It's got multiple general topics like UTI and common things, and it got specialties like oncology deals with cancer, stones commonly known as endourology, functional urology where the men present with LUTS or including women, andrology, infertility as we said, pediatric and reconstruction or another specialty. It's got lots of good subspecialties, so you will enjoy the variety when you're in the urology posting. by which we are completing today's talk. It's almost an hour and 10 minutes. I don't think anybody have stamina to hear more than this, but I can talk. I'm quite happy to answer any questions you have. Any burning questions, anything? Yeah, it's good. How do you treat a testicular torsion? Yeah, it's a good question. I will do a shop share so that we can discuss it much more better. Okay. So, testicular torsion, as I said, it happens because the testis is supplied by a pedicle. The pedicle has the testicular artery and also multiple veins which drains the testis. So, if the torsion happens, then like a hose pipe, the blood supply to the testis is compromised. So, we need to make an incision in the scrotal skin, examine the testis, see first that whether the testis is viable. If it is viable, then try to rotate it. You can see even the spermatic cord where the twist has happened, and rotate the testes so that the blood flow will be established. You can see in theater on the table a dark husky looking testes. Once you undo the twist, a good flush flow of blood comes in and the test is becoming nice and pink, etc. And you can ask your anesthetist to give a little bit more oxygen and then look for the viability. Once the testis is proved to be viable, you can fix the testis. So fixation can be done by sutures, which is known as 3-point fixation. So if you fix by 3 sutures, it's 3-point fixation. The other one is, the testicular surface, the scrotal surface has got detrusor. You can create a pouch in the detrusor and keep the testes safely into the pouch so that the testis has no space to rotate again. So these are all the two ways by which you can fix the testes, which is known as orchidopexy. Pexy, it definitely means fixing, and orchido means testes. So the scientific term is orchidopexy. That's how we treat the testicular torsion. The other question is strangulated hernia. It's not belongs to my specialty. I'm a urologist. I'm not a surgeon. But today is a Black Friday offer, so I will try to explain few things on that. So hernia is the one. Say for example, if you are taking inguinal hernia, you have got inguinal canal on the left side and right side. In a child, the inguinal canal is not there because the external inguinal opening and internal inguinal opening are one above each other. As the child grows, the openings get far away, that results in the inguinal canal. If for any reason, if the inguinal canal is patent or if there is any intra-abdominal high pressure, the contents of the abdomen tries to come through the inguinal canal. If they come through the inguinal canal, it will pass through the internal inguinal ring, inguinal canal, external inguinal ring into the scrotum. So that is the hernia. It is the definition for a hernia. If it happens through the inguinal canal, it is known as indirect inguinal hernia. If it happens through the back wall of the inguinal canal, it is known as direct inguinal hernia. When the hernia happens, what happens is it's a very small opening. You can take for example maybe like a 20p coin, okay, and initially small amount of bubble comes through the hernia and the blood supply is nicely maintained because blood supply also comes through the hole. But when the patient coughs or strains, slowly the amount of content in the hernia will go on increase. So initially it's only like a cough impulse, which means the hernia will come out, and when patient relaxes, the hernia will go in. It is known as cough impulse. When the patient coughs, you can see the impulse, hernia coming and hitting your hand. That is cough impulse. But once it is nicely established, you can see the hernia is persistent. You will still have cough impulse, but hernia won't go back. If it goes on for days and days, if the patient is ambulant and goes on straining, lifting heavy weights, cough, etc., then slowly what will happen is the contents will be too much and the hernia neck is small. The amount of blood flow through the small neck is not enough to support the blood supply to the full contents, and also sometimes the contents, like for example feces, will come into the hernia and it can't go back. That's where it is known as obstructed hernia. Obstructed hernia means the hernia contents are obstructed, it needs emergency surgery. The next one is strangulated hernia, which means the blood supply to the hernia is compromised. If it's not operated in a quick time frame, the whole bowel can go necrosed. We have come across very rarely patients coming from very remote area where they get strangulated hernia. If you do a laparotomy and see, if you reduce the hernia, that particular bowel segment alone is dark and strangulated. We need to cut and sacrifice the strangulated or dead segment and do a fresh, nice segment end to end anastomosis. That is strangulated hernia. So it's indirect hernia and direct hernia, and then it's like hernia which is reducible and irreducible, and then the hernia which becomes obstructed, only the contents were obstructing, and the next stage is the blood supply is getting obstructed, it's known as strangulated hernia. Okay, any other questions? Okay, I'm available, and you can easily catch me through the name in the yeah, thank you, in the canvas. I encourage you to drop any questions if you have. I will edit this video and try to make it available in the canvas, and I will try to change some slides if needed, but I don't think it's require major changes. I will leave the prostate cancer presentation as it is because it's very updated only last year, and it's nice to know about the prostate cancer, about because the chances of, if at all, if there is any urology question in the MCQs or OSCE exams, the chances of it related to prostate is almost 50 to 60%. That's why I want you to have a kind of an extended syllabus. But looking forward to see you in year 4, and when you are posted for urology postings in Sanville and city hospitals, I'll be there to guide you. Okay, if there is no, oh, there are some more questions. Yeah, it's only thank you, that's very good. If there are no further questions, we can call it a day, and wishing you a happy weekend, and but learning continues. Feel free to ask any questions, and yeah. Okay, that's very good. Okay, nice weekend, everyone. Bye.